So thank you for being with us today in this symposium. Raul Nogueira and myself are going to present about the direct transfer to the angio-suite triage for faster treatment and exciting plans about the new randomized trial that we're going to launch shortly. This is an overview of the presentation. So why we do believe in direct transfer to the angio-suite? Everything starts when the patient comes with the ambulance to our emergency room. Ideally, we should have been advanced by the pre-hospital's alarm system that the patient is coming. Once the patient is admitted, what we basically need right now is these triage steps. First, we need to exclude that the patient has a hemorrhage, a large established infarct, and we need to find out if he has a large vessel occlusion. Obviously, we're not going to do the same according to the time from symptoms onset. And the same way that over years we were able to reduce and improve workflow times in the TPA treatment, in the door-to-needle metrics, as you can see here, reducing from more than 100 minutes down to 15 minutes, as we increased our number of treated cases, we may be doing the same with the door-to-groin puncture metric. So therefore, those are the possible pathways that we can follow when the patient arrives. First is go through the ER, what we call the ER code that we absolutely try to avoid when we have a pre-hospital warning that the patient is coming. We have what we call the CT code, transferring patients straight to the CT scan. And in some cases, we started, and several centers already started, in those cases where there is pre-notification with a confirmed high NIH score on arrival within 6 hours to transfer the patient directly to the angio-suite. So, in order to do so, right now we are promoting pre-hospital alert, as I said. We tried ideally to avoid and skip the ER and ask our technicians to send the patient directly, transfer him directly to the CT scan. Immediately after non-contrast CT, we can already start IV TPA bolus in the CT scan, and we prepare the pump, the infusion pump, while we acquire the rest of contrast imaging. And after that, we quickly analyze the results and we go to the next stop. So, without any doubt, the door-to-puncture time is associated with outcome. And you can see from this study that there is a great variability in the performance of different sites around the world. But in any case, there is a clear relationship. The longer is the door-to-groin time, the worse or the poorer is going to be the outcome. Even the most recent studies showed that the performance is clearly improvable. So this is an extreme case that illustrates very well why we can perform a direct transfer to angio-suite. Imagine a perfectly fine patient that is coming to your angio-suite for a diagnostic procedure, and at this exact point he develops an hemiplegia. Most of us will concur that there is no need to take this patient out from the angio-suite to the conventional CT to acquire imaging, and we can just perform a con-beam CT to rule out a hemorrhage, and if there's not, we can proceed with groin puncture and thrombectomy. So now the question is how much we allowed internally in our mind this time frame before we concur that we don't need conventional imaging. Is it 3 hours, 4 hours, 6 hours, 12 hours? This is the elapsed time that we need to find out. In any case, from previous studies, we know that despite there might be a decay in the rate of perfect aspects, patients being admitted with aspects of 10 as time from symptoms onset is greater, the number of patients in which the aspect score is below 5 is really low, up to 6 hours, and more than 95% of the patients will present with an aspect score compatible with thrombectomy, meaning that doing many imaging, lengthy imaging in these patients most of the times will not be necessary. So how far from symptoms onset is direct transfer to angio-suite still beneficial? we performed a case control study in our with our patients, and we observed that the treatment effect of direct transfer to angio-suite was higher the shorter the time from symptoms onset. Here we can see, as when we compare patients within 3 hours and more than 3 hours, and you can see how the treatment effect is lower and lower as time is greater from symptoms onset. Another question that we always ask ourselves, what about direct transfer to angio-suite and IVTPA? Are we denying IVTPA to these patients? So we did also a study to investigate the safety of giving IV thrombolysis to our patients based on cone beam CT. And we observed with 20 patients that were treated that there was not an increase in the rate of hemorrhagic transformations in these patients, and neither on mortality or any other complications. Meaning that we can safely give IVTPA based on a cone beam CT imaging. So as of today, there are multiple published series of centers that are performing direct transfer to angio-suite. All of those are confirming great reductions in the workflow times. Most of the times, door to groin punctures are below 30 minutes. What needs to be proven is the clinical efficacy and the benefit that we're offering with this workflow.
Good afternoon. It's a pleasure to be here to talk about direct to angio-suite and the We Trust randomized clinical trial. We were planning to start in the near future. You just heard from my colleague, Mark Ribble, the co-PI of the study, some of the rationale and the data on the direct to angio approach. Over the next 5 minutes, we're just going to summarize a little bit what you know about the current technology, as well as some of the aspects of the We Trust trial. So we know that the cone beam CT technology is improving rapidly. Recently, Philip has come up with this new system where, as opposed to have a circular type of rotation, the II actually rotates in a helical manner, and with that you can actually have a lot less artifact and a much more refined image. As you can see here, this is what you obtain with the circular acquisition. This is what you obtain with the helical acquisition. You can see that the borders are much well defined. You can almost see even the details of the gray-white matter differentiation. So in the near future, it's possible even to potentially look into aspect scoring strokes, because you're getting rid of this cone beam artifact, which has been an issue. At the same time, the time of acquisition of these cone beam CTs has gone down dramatically. Here you can clearly see the evolution of the cone beam CT technology, starting with the Expert CT in 2006 to the new detector technology in 2014, and now we have this helical technology. You can see that the images are significantly better than before, and they approach what you see with conventional multi-detector CT technology. Again, another case here to highlight how much better the image is. You can actually see the contours of the brain a lot better, and you no longer have this transitional artifact between bone and brain. Here you have the sagittal reconstructions, where you can see essentially disappearance of the cone beam artifact, while you actually have much faster acquisition times, which also decrease artifact in return. Another example here, looking at the conventional Expert CT versus the optimized protocol with the helical rotation, and the comparison with the multi-detector CT technology. So why we perform this study? The reason why you're performing the We Trust study is we believe stroke treatment should mirror the pathway that it's seen in ST elevation MI, myocardial infarction treatment. If we follow the footsteps of cardiology, right, it's clear that cardiologists, they could have had the approach of making an acute MI a fancy scan. They had the myocardial perfusion scan technology available to them during decades ago, right? However, what they decide to do is equate acute MI to fast reperfusion rather to more refined imaging technology that oftentimes only leads to overselection and exclusion of patients that can still benefit from treatment while actually delaying treatment, and these are very time sensitive issues. So we do have the EKG for the brain. That's called the NIH stroke scale. In fact, we know that if you activate our stroke lab for any NIH stroke scale equal or greater than 10, the rate of false positive activations in our cath lab would be less than 20%. Okay, maybe about 12% cases would have ICH, about 7-8% of the cases would be non-LVOs. Well, the reality is when they activate a cath lab for an ST elevation MI, they have a false positive cath lab activation rate of 10 to 30%, which is not very different. It's exactly at the midpoint where you are, right? So these are very similar things. And that's why then we designed the WeTrust study. WeTrust stands for Workflow Optimization to Reduce Time to Endovascular Reperfusion for Ultra-Fast Stroke Treatment. It's not only being fast, we now have the goal of door to puncture times of 60 minutes. You actually want to reduce that goal to less than 30 minutes. And the only way we can do that is if you take the patients direct to the cath lab. So the objective here is to demonstrate that the direct to angio-suite triage workflow involving the cone beam CT technology results in superior patient outcomes in the treatment of ischemic stroke with confirmed large vessel occlusion as compared to the conventional imaging pathway using either CT or MRI triage. The trial will include a total of 16 centers, 506 patients. The centers are distributed across 9 different countries in 3 continents, including Europe, North America, and Latin America. We expect to complete this study in about 2 years. The primary endpoint will be the modified rank scale at 30 days. And the patients that are targeted for therapy are the first 6-hour symptom onset patients with an LVO. Here is the study workflow. Essentially, when acute ischemic stroke patients present, we're going to screen them for age, and we will include if the age is equal or greater than 18, baseline NIH stroke scale equal or greater than 10, the pre-morbid modified rank scale 0 to 2, and again, during the first 6 hours from time last seen well. If the patients qualify, they will be randomized not for treatment, but rather for treatment selection modalities. So they either will go to the conventional pathway with CT or MRI, or they're gonna go to be going straight to the angio-suite and then having the cone beam CT evaluation. The patients are gonna be stratified by age, NIH stroke scale, use of intravenous TPA, whether or not they are outside transfer or mothership, and the participating site. Once you obtain the imaging, we then will exclude intracranial intracerebral hemorrhage, and we will verify for the presence of a large vessel occlusion defined as intracranial ICA occlusion or M1 occlusion. The patients that do not qualify still are going to be followed for the safety portion of the study. Otherwise, they're going to be part of the intention to treat analysis for the trial. And obviously here the decision based on the imaging findings will be thrombectomy or medical on both sides, either conventional image or cone beam CT, but everybody that qualifies based on the absence of hemorrhage and the presence of an LVO will be qualified and will be followed for 90 days, and you're gonna see then the differences in outcome at 90 days across the 2 start arms. So we trust that together you can make an impact in the future of stroke treatment with this trial. We do believe this is like one of the major boundaries, frontiers that you have to explore in stroke treatment. And I'm very grateful for your attention. Thank you.